This is the Equity Charter podcast, where we talk about why we care about equity in the digital health sector and why we think you should too. Welcome to this week's episode of the Equity Charter podcast. My name is Aisha Rahim and I'm a psychiatrist and Chief Clinical Information Officer working in the NHS. Along with my colleagues Hassan Chowdhury and Victoria Betton, we developed 10 principles for embedding equity within the digital health sector. For this week's episode, we'll be looking at Principle 4, which is equity at the centre of digital strategy and transformation. And here to discuss this topic with us today, we have our two experts, Hatim Abdulhussein and Joan Saddler. Welcome to the show, Joan and Hatim. How are you both doing?
Thank you.
Yeah, pleasure to be here.
Great. Can we start off with learning a little bit about yourselves and your current role? So Hatim, I'm going to come to you first. Tell us about what you do.
So first and foremost, I'm an NHS GP and I still practice in North West London, but I've had a slightly strange career alongside that. So when I was training as a GP, I did a National Medical Director's Fellowship at Health Education England. It was a time that the topical review was being done, among other things, and that piqued my interest in digital and technology and the potential of all of that. And so went on to work with others to find a TOPL fellowship program and to take on some leadership roles in digital, but actually did a lot of reflection that I had done that in the past, which I thought was interesting, even as a foundation doctor. And I took on a role essentially as a clinical lead for AI and digital and robotics within Health Education England, followed that work at NHS England in AI and digital workforce, and then joined the Health Innovation Network in Kent, Surrey, Sussex as their medical director, and now have the pleasure of leading the HIN in the southeast that is responsible for that population. So as I said, a slightly strange career, but have managed to protect my clinical career at the same time, I think, which is really important too.
Really interesting. I always love hearing about people's circuitous routes in their careers. Joan, what about yourself? Tell us about what you do and how you got to where you are.
Yeah, similar kind of routes. I got into health as a non-executive, actually. I worked and managed a charity for a long time and saw the opportunity to do a lot more with local communities. So at the moment, my role as Director of Partnerships and Equality at the NHS Confederation is part-time. I do that. I also sit on boards as a non-exec. I also previously chaired a PCT that allowed Primary Care Trust, that allowed us to get some real work done in communities with not just a hospital, but everyone, including obviously primary care and its constituent parts. And we're able to lead on some really interesting things, including access. And access at the time, and this will make some people laugh, over 20 years ago, was making sure our community health visitors had access to mobile phones. And it changed their working life. So I'll just leave that one there with you. But since then, done some executive roles at the Department of Health as the National Director and also currently co-chair the Equality and Diversity Council. So it is about working with all people to ensure our access, experience and outcomes are better. And digital is one of those ways we could ensure less inequality.
Fantastic. So again, very broad, extensive experience of this space. So if we can kick off with the first question, why do you think it's important that we think about equity at a strategic level? Because, you know, of course, there are lots of people interested in equity and lots of small projects that go on. But from a strategic perspective, why is this important?
Equality and equity, there's lots of reasons why people use different words. They're both important. One speaks to our statutory requirement to ensure that the whole population gets the health it requires and that we map according to law, whether it's the Equality Act or the National Health Service Act of 2006, everyone gets the access to the services they need and our staff are treated in equitable ways to ensure they deliver the services they need. So this is really important. Staff as the input, how can we have staff in all its diversity delivering to a population in all its positive diversity? It's important we see this work at a strategic level because it has evolved over the years. And if we think about the 2000 NHS plan, where at the time we had more money coming in, the opportunity to start to transform the system, we see that diversity of not just staff, but the ways in which we deliver care has kind of mushroomed. And we're now back to the place in 2026 where we're seeing another plan trying to transform the NHS. If we don't transform the NHS with people and with the beauty of all of that diversity, it won't succeed. So it makes sense to try and think about what are the principles we're using here to ensure we're co-producing with staff, with our patients, with the public, and with people who can help that partnership approach to delivering transformation in a very strategic way. Without that, we just get nice programs and a bit of food at events, and that's not transformation. So this is important.
Yeah, and building on that, so if we go back to the fundamental principles of the National Health Service when it was launched in 1940s, I mean, it's very clear in terms of, one, of course, a universal healthcare service for all, but the underlying principles are around integrity, service as far as I'm concerned, even if you go back and read the speech when it was launched. And then to build upon that, if you look at the Institute for Healthcare Improvements quintuple, the model for an ideal healthcare system, within that, you've got, of course, things like a healthcare system needs to be cost effective and so on. But actually fundamental principles to that are an equitable population health model, are the positive staff experience in the quintuple aim. So we should always be striving for those things when we're delivering and transforming a healthcare service. And it should be fundamental in our thinking and in anything we do, be it digital, non-digital, designing a healthcare service from scratch or improving a healthcare service from where it is at the moment, and want the values of those principles to be inherent in everything that we do when we're doing the work that we do. And I think you see it in the 10-year plan and another policy that's come out in recent times.
Yeah, and I think there's also that evidence base, isn't there, about making sure that we do have some top-down ownership of this rather than simply looking at a ground up, which is great, and we probably need both, but certainly having that strategic, stated, explicit aim does feel like it's the best way of getting us to where we want to be. And so I was also thinking about strategies around equity, and I suppose there are different ways of enacting this. And there's a debate, isn't there, about whether these strategies should be separate and explicit or whether they should be bundled in with other existing strategies. And I just wondered if either of you had views on that.
Yeah, I mean, I can talk about a couple of examples, I suppose. So I chaired a primary care trust that was new and had a leadership that reflected its population. Whether you're reflecting the population or presenting views of a population is really important. So it's not always just about reflecting. But if we think about why we do that, it's because strategically we're trying to deliver healthcare, we're trying to plan and deliver and commission healthcare to everyone. So a strategy must be central to your equity strategy, your equality strategy. I'm using both because however you think these words apply to you, they're important in strategic terms. So my PCT would be thinking about what are our business goals, who do we need to engage, actually explicit patients, and how do we need to ensure that each of our strategies, whether it's our OD, our HR at the time strategy, whether it is our strategic development strategy, whether it is our future, how do we make sure we've got the kit we need? All of these different bundlings of strategies were important to the main strategy. What we understood in our PCT, we'd never had a strategy that was just about communities or about engaging people. So I'm answering with two ways of looking at this. Any strategy that talks about equity must be knitted into a main strategy. You would think that's quite obvious, right? Mm-hmm. But the NHS has for years talked about equity as an input. We need diverse members of staff, and we definitely did, and we still need that. And by diversity, we mean across the protected characteristics. And then when you think about legacy of who we are, the ways we think, and the ways we learn. So kind of speaks to that thought diversity model. So we knitted that into our overall business goals year on year. in terms of what we would do. Unless we do that, we're tinkering at the edges, aren't we? I suppose the second element would be there's a how. How do you do this? Various organisations either straddle will have someone in charge and a team, or more so nowadays, you have someone who will oversee a team that's virtual, that works throughout the organisation. My one rider would be to say, let's look at all the evidence of mainstreaming. When you mainstream, this issue can get totally lost. And so you still need senior leaders with direct accountability and responsibility, as well as some challenge in their roles, to be able to hold the organisation and colleagues to account. How are we actually developing and delivering our commitment to this issue in practice? Organisation strategy, and then you need an equity and equality strategy, whatever you might call it, equity and inclusion. What matters is what it produces.
Yeah, I think it's a great point. And the reality is a lot of it depends on the maturity of the organisation and the shape of its leadership. So, most organisations that have that don't have that level of maturity need to have a specific equity, diversity, inclusion strategy, and need to be enacting that. And we've seen that in some organisations in the last year that have had to go through that process because they just don't have that level of maturity. And where they do have that level of maturity, then actually it's very easy because, and I've seen this in a couple of strategies that I've worked on in the last 6 months. So one is the digital strategy for the southeast of England. Because it's forefront of our thinking, almost one of the most immediate questions is, what role is this going to play in the strategy, and how we're going to be thinking about things like digital inclusion and so on. So, it's really at the forefront of our minds because it's a mature organisation in that thinking, but some aren't, unfortunately, and therefore they have to do a lot of work to get themselves to that level.
I also think I agree with that, and I also think that the point about leadership just can't be missed. So when you say we've come a long way, I think we do. We have different leaders, and by that I don't just look at myself, because people think I'm talking about black people or brown people. I'm talking about different leaders. That's what our equality and inclusion strategies are about. How do we go even further than those within the protected characteristics to bring their knowledge, their expertise to bear on delivering the best healthcare? And without leaders who really want to tackle that, you've got an uphill struggle. So I'm just going to make that point.
Yeah. And I really like the point about differing or flexing your approach depending on the maturity of your organisation, because actually not everybody is starting from the same points, really. And I think knowing that there's not just one playbook, actually, you're going to have to do some reflection and thinking about your own organisation to get the most impact out of this.
Just as one thing I'll make about power, because that's what I really experienced as a chair, and then coming in at a national level and leading work, which was about people and partnerships in all their diversity again. Power has a lot to do with where this notion of not just digital strategy, but strategy goes. And coming into an organisation that had no diversity in its top team in the middle of London was, for me, not acceptable. And actually we worked on it, and within a year we had the most diverse board in the country. Now, why am I saying that? Because the organisation wasn't adept at equality, wasn't very good at it, but actually within a year that leadership had progressed to healthcare commission scores at the time that it up to first or second in the pack, because we knew how to engage with our population, very diverse, and have a diverse team to deliver that. So this idea of leadership again, right, even if you're not very good or you're not sure what you're doing, but the intent to get there and to bring in the resource you need to improve is really a point I want to hammer down. Don't be scared of it. If you're a digital leader and you're thinking, where do I start? There's even more knowledge out there than there was before.
And I think that is really important, that message of hope as well, actually, because things can change. It takes conscious effort and leadership, as you say, but change is possible. So, of course, there are some tools that are available for people to guide them a little bit. And one of those examples is the equality impact assessments. And I'd be really interested to hear both of your perspectives on whether these are tools that are helpful. Are they effective? What's your take on that?
Shall I come in first? I think they can be used well and they can be used very badly. So equality impact assessments are essential for even public sector bodies who might not be wedded to delivering something that's called an equality service or an equitable service in terms of planning, background commissioning. But actually, if we understand as a public sector body, there is nothing that we do that doesn't need an equality impact assessment. That's the first stage. So my example would be finance, and I'll say to finance colleagues, do we need to take account of where our money is being spent across our population, our grouping? Could be regional, it could be system-wide, it could be hospital. And they'll obviously say yes. Then I'll say, and do we need to make sure that we're tracking where there might be more or less inequality and what we can do about that? And undoubtedly, yes, of course, we need to do that. How do we do that? Then is simpler or more complicated depending on what you're talking about. And the emergency care department is one of those, okay? But we've seen again how Core 20+5 came in and said, here's a way to track who's coming in and out, what the cost is, how do we make sure that the highest users are getting what they need, and that might not always be in a hospital. How do we work in partnerships, so both acutes, community providers, independent sector providers, people who work in voluntary organisations are helping us deliver this more efficiently and productively so that people are getting what they need. It's an obvious example, but I'm just making it again and again, because if you ask any director of HR, strategy director, do we need an equity approach? They'll say yes. What we're poor at, particularly at boards, is answering the question and knowing why we're answering the question on a board paper that says, what is the equality impact assessment? And too often we're thinking, oh, there is no equality impact here because there's no negative impact. Whereas an equality impact assessment almost starts with appreciative inquiry. What we're doing well, what do we know we've mitigated against, what do we need to watch out for, and what are the mitigations? If we can't answer those basic things, we are developing really nice-looking policy that might actually increase inequality.
I think that's spot on. So the benefit of these tools is they're developed on best practice on legislature and give a level of conformity that any organisation can use in various different domains. But the risk is exactly what Joan highlights, which is it can become a little bit of an activity that doesn't necessarily have the underlying rigour to it. It's a kind of very high level, and it doesn't then actually allow you to change what you do. And then there's an element of you need it, but then what else sits underneath that? And I can speak, for the innovation agenda, for example, we've done a lot of work just to say, what are the principles for health equity and what are the toolkits to be able to allow innovators to be able to develop solutions that are meet the needs of equity, but also commissioners to be able to commission innovation tools that actually benefit and promote equity. And then similarly, how do you build further from that into what needs to go into procurement or what needs to go into what we report on and so on. So there's a level of benefit these tools give you, but more work needs to be done beyond them. It can't be seen as now we've solved it just because we're applying the EQIA.
Yeah, and that's one of the questions I had really, is because it's when it's done poorly, and I'm sure we've all seen examples of this, it's a tick box exercise. So in terms of that tokenism and that sort of additional bit of paperwork that we have to do before we can get off the ground, where does that start, do we think?
So that's always going to be something we have to recognise. So then it's really about skills, capabilities, and understanding, and this is where again the maturity comes in. So it's not just about diversity in staff, but it's actually about the knowledge within staff and leadership in terms of recognising the importance of equity, recognising things like the quintuple aim and so on, and what helps you deliver an effective service. If people don't understand that and know those things, then it will just be a tick box exercise, and it won't allow organisations to go beyond that.
I think as well as agreeing there's so much information now, you don't have to go very far. Even if you look at the NHS England website, there is so much information on how to do an equality impact assessment well. I would also say there's information about how not to do them well, but, reaching out to EDI professionals who increasingly have that range of leadership skills that you would need to do this well. Increasingly, we are seeing directors, associate directors of EDI or health equity, so they work across both workforce and health equity, which is the preferred way. If you look at what the evidence is telling us, let's join these up. There are some people and resources who could talk about, or who could show that the way to deliver an EQIA is to see it as an essential part of your toolkit. As a leader, if you don't understand what you need to assure yourselves that service will be commissioned or delivered well, in terms of an EQIA, that's a failing of the system, right? And we need to then arm ourselves. There's plenty of ways you can do that. We run a course for the EDI directors stroke tackling inequalities leaders. It's for people who are senior responsible officers. And the first thing we do is we take them through at the beginning of the course. So it's a year long. What are we doing and why are we doing this work when it comes to tackling equality through equity? And all we do is we go through the strategy levers, the strategy approaches, the individual plans that the core NHS is following, and then we link those plans to the equality legislation and the way in which organisations are developing their equity and equality approaches to meet those strategies. And when you map them, they're actually quite straightforward, but nobody takes the work to do that, and nobody's got the time to do that. By the end of the day, I'll never forget one of the first feedback in-person pointers that we had, and it was, I was so glad you didn't preach to us. That's what we were expecting, and actually this is much more. So taking the time to link and go back to the first principle, again, 1948, the NHS was set up to tackle health inequalities, right, and workforce inequalities, because people were choosing to eat or to treat. We know that story well, but let's not forget it. So why have we moved now to a programme of tackling inequality when that's what the NHS was there for? It's there to treat all of us. Let's get the skill set higher, and all of us have got some work in doing that, but there are people out there who can assist.
And that's a really great segue into some of the work that Health Innovation Kent, Surrey, Sussex are doing, because I know that you've got some toolkits for innovators. But I just wanted to start off, Hatim, by asking you, how far is this on suppliers' radar, on innovators' radar? Are people thinking through an equity lens at the moment? What's your experience?
I think there are some considerations, and we do a lot of engagement work, obviously, with innovators on this. So we talk them through the toolkits, we talk them through the importance of equity and designing technology or innovation that meets those needs. But a lot of it will reflect what the buyer wants or what the procurement process is, because these are organisations largely looking to enter the NHS, enter the market, and sort of secure contracts and so on. So a lot of their activity will be driven by commissioners, really, I would say, or buyers or technology in providers. And so if they're not recognising the importance of this, or if there isn't a large licence given to this in procurement contracting or tendering, I suspect. But the good innovators and the ones that are most likely to succeed will be thinking about it right from the off. And we know the best innovation is innovation that has been co-designed and co-developed with people from various different backgrounds, with service users from various different backgrounds, because actually that's more likely going to help the innovation to succeed. And it helps to solve problems like where, for example, there might be a specific innovation that looks like it's going to have a potential benefit but completely excludes a certain part of the population. You will get challenged. And we've seen that in technologies around AI, for example, where actually the good innovators in those spaces are thinking about it right away and thinking about how they build the evidence in that space. Recognizing that it's not easy because of the data or because of the way the models are trained or whatever it might be, and therefore extra work needs to be done to put something in place, and the right engagement needs to be done with the right bodies to be able to enable activity in that space. And so we see the examples of best practice and poorer practice, and what we try and do through our engagement with innovators, through our things like our discovery program, is try and lift everyone to the same level of playing field so that you've got a much more consistent approach and less variation. But I do think there's more work to be done on the buyer and the procurer side.
That's really interesting. And I know, Joan, you've had examples that you've talked about in the past where those unintended consequences come into play? So people starting off with a great innovation, be that digital or something else, but they've just not thought about the impact of that. And I'm just wondering if you could say a little bit from that perspective.
Yeah, so there's one on the general point that's just been talked about of this whole kind of building trust with patients and the public. Co-production, absolutely important, because it's not that should people go into a digital world, and some are choosing not to, by the way. It's how people access services and experience high quality outcomes. It's not just access. How do they experience high quality outcomes requires a kind of trust building that says, okay, we'll come along with you so you can have the best tech. So co-production that you've just said, really quite important. An example of when we haven't involved people well or thought about the unintended consequences. I talk quite a lot about the recent race almost to secure weight loss jabs for the whole population. And mentioning no brand names, we're not doing that today, but there is something about a health inequality impact assessment and various EQIs that showed the high likelihood of those being able to pay would access particularly online medication more easily. Then there were the unintended consequences of people accessing that medication who may be seen, particularly by your first line, your GP. That starts to clog up the system again. In terms of accessing just appointments, you can see the knock-on effects. So the EQI wouldn't have said, don't do it. It would have said, mitigate for when we open up the gate so that actually we can use kind of weight loss jabs for its intended purpose so that people are getting the help they need, particularly people with morbid health. They have, really a need for this approach. So again, not ignoring the health inequality impacts. And lastly, there's something about those who are delivering digital technology. It's very real that we're in a world where inequality is not just within health. We've seen in a global world where talking about difference is a negative, it's not an asset, and it's almost as if we're pitting groups against each other. If we've learned nothing else from 1945 and what happened at the end of the war when we saw the length that hate can go to, we should be thinking about making sure that everyone accesses in a respectful way, as is the NHS Constitution, and that as we continue that respect for all, we want to think about those companies who are on the production line, who are delivering technology and digital technologies at that, who might not be actually, let's just say, demonstrating the most equitable approaches to people and whole populations, i.e. denigrating populations. As an NHS, should we actually be involved with those companies? Now, companies, the NHS want to be involved with you. And so let's make sure we're not just talking nice social responsibility words, but we're talking about the ethos of our organisations and those leading those organisations. It's going to cost you. Indeed, we're seeing some information or research already talking about those in the US in particular, bringing them back in because across the world they're losing business.
I mean, just to add, actually, so there's two really important considerations. Those that experience the poorest outcomes in areas where a lot of these life science companies are developing medications in cardiovascular disease and so on come from specific backgrounds. We know the evidence shows this, either lower socioeconomic status or have a protected characteristic. Able to recognise that right from the off, and a couple have done work with us in the last year to read and look at this and create pathways that actually best access those populations, considering the voluntary sector, considering social enterprises, considering faith centres. There are different ways you can model services, and also really looking at the data right from the off and working with that data. The second consideration is when people are developing technology or digital pathways to care, we recognise that actually that does create challenges because some people may not have the digital literacy skills, and we know actually a significant part of the population don't have digital literacy skills, let alone health literacy skills. And so that creates a huge challenge. And that's not to say we shouldn't then create digital pathways, digital front doors, but we need to do the right modelling to ensure there are alternative pathways in place and protected for people that have those challenges, and then also work with those people to be able to upskill them to have the right health and digital literacy to be able to access the new ways of accessing healthcare through technology. It's all doable. doable, but it requires that thinking from the off and working together towards that mission.
And picking up on what both of you are mentioning, I'm really interested in this concept of, I think it's a misconception really, that if you ask the question, you might get an answer you don't like, which might kill your project, when actually that isn't the case. I think what we're saying is that, well, you need to ask the question because it has a significant impact on the stickiness, if you like, of an innovation. But also, you just need to do some additional thinking about how you mitigate for those people that are missed out. It's not about throwing the baby out with the bathwater. And I just wonder whether that's something that people fear, that stops them even asking the question in the first place, because they're not sure what they're going to find.
I think one of the challenges is we have this concept in the NHS of pilot successful in your initial pilot. You're not going to be able to be successful in having that technology or innovation commissioned on a longer term basis. And the reality is, innovation isn't easy, and it requires iterative improvement as part of the pathway, and it requires co-production and co-design, and all of those things take time. So you can recognize some of the challenge for organizations that are looking to secure contracts. These are ultimately businesses, and therefore businesses in a really complex space with lots of competition and challenges around investment and so on, who are trying to keep the lights on and keep people employed and so on. So you can see where people are coming from when they're perhaps seeing the challenges of doing this well. But as I said, and you raised the point, stickiness is the most important thing and success is the most important thing. And the reality is, if your innovation is unlikely to be successful, if it creates or it widens inequalities, it's just not going to stick. It's not going to continue. And so if you're not thinking about that right from the off, then you're actually at a disadvantage.
Yeah. Can I add to that? Because I think it's a really good point about thinking about it and adding to your advantage. I remember being in the room with mostly digital leaders. This was just before COVID. And I thought, I haven't met who are these leaders? Because we're almost siloed into, we lead different things, medical over there, digital, increasing space, managerial. And so it really struck me that what they had to offer this room, and I was doing a fast track of, right, what is the digital that they're actually developing now? It really struck me that never the twain shall meet. And actually, there's such an opportunity for digital providers, which since just before COVID, we are seeing now with Health Innovation Networks doing a pretty good job. That's not a plug just because you're here, but there is a good job. But it's been hard work, hasn't it? So coming back to what's the opportunity, I kind of said to them, look, you digital providers, if you are co-producing and working with communities, there is a gap there. And one of the gaps is, to complete the heresy that I'm about to say, one of the gaps is, how do you mitigate for people who don't want to use digital at all, but actually there are routes through which they can still get a service? Let's go to 80%, but there'll be the other 20%. If you can do something about signposting people to sources of support, as well as those people who want to use your services, you're getting an advantage. That's a basic example, but you can build that through what was just said, right? And I think it's somewhere, there's a poverty health map that Cheshire and Liverpool ICS have developed, and it's done just that. It's worked with a digital provider to say, let's look at where the digital resources are, and let's look at what non-digital solutions like street surveys and working with pharmacists can tell us about our demographics, our districts and wards, our type of digital resources, so that we can then make sure we're developing much more productive services, much more efficient services, and we're truly meeting the needs of populations. It was, one of my team found that example, and I really liked it because it speaks to choice as well as fast tracking a better experience of care without excluding people.
Mm-hmm. Okay, and so we've talked a little bit about where strategy and digital equity or equality strategies aren't done well. I'm just wondering if either of you have got some examples of where things have been done really well, really robustly, and what were the key factors that made those a good, robust digital equity strategy?
So NHS England actually went into delivering services around digital skills and capability for people coming back into nursing. So they were returners, and Health Education England at the time then subsumed into NHS England developed an approved blended learning in nursing course, returning to practice after career breaks. What I liked about that was that these could be healthcare assistants who wanted to go up the ladder, had no time, had no money for tech, and they provided the tech through this course. And there are a range of at least 5 universities now running them after its inception. I think it was in 2023, across the country. And the blended learning approach means that you're attracting more men, you're attracting more black men, and you're attracting people with disabilities more so into nursing. I think that's pretty good. Again, there are some pilots that then have developed this course. But again, equity isn't just on the sides. This is about digital training that can help us to end the workforce supply issues that we do have in this country. How do we upskill different communities into roles that they wouldn't have thought of before, and they become careers with the support they need, because some are from disenfranchised or poorer communities who wouldn't be able to afford this kind of course.
From my end, look, I think the most important thing here is, and this is what comes back to my point earlier on, which is if policy is in the right place, how do you then link that into strategy and action? And so one example that I've seen over the last 3 years was a program of work called the Inequalities for Healthcare Improvement Program, which was set up by the centre. And we, the Health Innovation Network, did some work around that specifically too. So what we did is then building upon Core 20+5 and identifying where some of the underserved communities are perhaps not getting the needs in terms of access, experience or outcomes, then joining it up with actually what technology and innovations are solving those problems, specifically for things like lipids or blood pressure optimization, and then targeting those interventions at those underserved communities led to some significant benefits. So again, it really is it's that whole follow through again from strong, clear policy that people can take on, having a strategic approach in your thinking and then delivering on that.
Okay, I'm just wondering global examples of how we can be better and how we can take that international learning into the NHS and into our health sector, our digital health sector here.
So there's very good examples globally around much more mature health systems when it comes to digital and data. And there are some health systems which are very different to our health system. But if you look at areas like Estonia, Finland, very digitally driven, very data driven, and have done a lot of work to support their citizens to be able to have access to what they need to be able to have healthcare provision, which is informed and data-led, but obviously have very different populations to ours. On the flip side, I think something that we don't do so well is learn from kind of what we want to describe as low and middle income countries and innovations that happen in those settings. There's a great book which is written by Matthew Harris, and that talks to actually what can we learn from innovations and initiatives that have been taken in low resource settings, because actually these are often the types of innovations that can make a massive impact because they don't require a lot of investment, especially in a system which is struggling fiscally. We can think about actually taking on some of those learnings and then of course applying technology and digital to them, or to the basic fundamentals towards those innovations. So I think we do need to be doing more learning from systems. I remember taking part in an initiative with the World Health Organization when I was at Health Education England, and it was looking at the telemedicine and how telemedicine is best being applied in different healthcare settings and systems. And it was fascinating just to hear about the role it was taking or in areas like Georgia, but also actually not looking too far away, how Scotland have used telemedicine in more remote and rural populations like the Shetland Islands to really deliver better healthcare to populations that have struggled with access. And so sometimes we don't even need to look too far away to best models of practice. And I think we just need to do more of that. I think we're very good at starting to look across England and perhaps the United Kingdom to some extent, but I think we can do more to look broader.
Great points. And it did remind me of Sir Nigel Crisp, who used to be the CEO, who ran the Health Service and Permanent Secretary at the Department of Health. He wrote a book, and it was all about how we transfer learning from what we now call the developing world, the South, as opposed to the West. And there's something about people always having to work with less, and so creating efficiencies in the how. The technology point, at the time, we had over 80 to 90% of countries globally now seeing populations that didn't have much cash, actually, but everybody's getting a phone. And this idea of, so when we talk about phone, we talk about, well, internet access, how do you get access? And we think computers, and just the way in which mapping, how are people using phones? What is the trust that they have in us? Here, there's lower trust, actually, in some communities who don't trust systems because of some of the systemic issues we've seen around working with disabilities, people with disabilities, or Black and brown communities. We can see some of that played out in the law. So looking at how people are using their phones, what the trust element will be is what they've done globally. And it's really worked quite well without even half of the resources that we have here. So always thinking outside of that box and not replicating how we use tech, thinking about how other countries have used tech. It's a very general point, but it's one you don't see a lot. And Nigel Crisp, and if I could remember the title of the book, but you'll find it, talked a lot 20 years ago about the opportunity for this to happen, and with some really good, well-evidenced examples.
And I suppose it harks back to that old saying that necessity is the mother of invention. So when you are in that low-resource situation, you're forced to come up with some great things. But yeah, it's how we now then take the learning from that, which has widespread benefits. So just to round us off for the day, any final thoughts or take-home messages that you want to give to people, either of you?
Yeah, one that I was thinking about as I was thinking about this podcast, what's the opportunity for people leading on digital transformation? So we know, and I think it was 2025, they got government consultation on digital inclusion, looking at their action plan. They estimated there's about 1.6 million in the UK living offline. Also, those who use digital technologies or don't use digital technologies are likely to have worse health outcomes. That's quite big for us when we're trying to bring in and transform ways of working within the NHS that give us greater access to preventative strategies. So I think there's something that in that digital space where it's a fast-moving world, and actually you're working with a world that's quite slow-moving. It takes a lot to change the NHS, right? The opportunity then is wide open for people, such as digital leads, to bring that fast pace of change, to understand it, and to translate what it means for the sector in a strategic way. Or else we're always thinking about pilots and small things that will move us along. Actually, it's the kind of thinking expertise that this category of leaders have that can help us actually get the NHS plan, get more work on prevention done, move stuff out of hospitals, letting hospitals do what they're really best at, as well as communities and GPs doing what they're best at. So we need your skills.
For me, it's partnerships, really, and we talked a lot about it in the podcast. I think this is a plea, really, to organisations both within the NHS and actually in industry and even with small and medium enterprises, is think about how you partner to, particularly with the organisations that have representation of diverse views, and I really look at the voluntary sector, the social enterprise sector, and the faith sector for that, because you're not going to design something or develop something that solves the problems that we're trying to work through if you don't do that. And the only way to do that is to work in partnership and really respect and value the views and the perspectives that those groups can give you. So that's really important. And then the second one is just accountability. And if we don't hold people to account, so we talked about EQIAs, but it goes beyond that. It really is about leadership, and it really is about culture. Outcomes that benefit a wide population, that improve access to healthcare for all, then we're not holding people to account for that, then we're failing.
Well, that's been a fantastic conversation. So all that remains for me to do is to thank you both for joining us today. Joan, Hatim, thank you. Thank you for tuning in to this week's episode of the Equity Charter podcast. Don't forget to rate, review and subscribe to the series. And if you'd like to know more, go to our website at www.equitycharter.digital. You can follow our page on LinkedIn, join our community of practice, and you can also contact us at hello@equitycharter.digital.